Good afternoon, everyone. Great that you're all here on this Friday to follow this meeting. Thank you very much to the organization and to Val Petty for the invitation to speak here today. We're together here to talk about improving implantation potential. My presentation today is on the psychological support of patients with repeated implantation failure. I am Eline Dancet. I'm a registered midwife, a master in science, and I have a PhD, and I currently hold an assistant professorship in patient-centered communication at the Leuven University. These are my disclosures. I've received an honorary for this presentation, and the studies that I will present in this presentation are funded by KU Leuven, Merck, and Flanders Research Foundation. I have no further disclosures. I will first focus on the problem that's for discussion here today. And then I will discuss the prevention of IVF discontinuation and potential strategies for that. So let's start with the problem. Discontinuation, or in other words, dropout rates are quite high. They are high after the first cycle, but they increase even after the second and the third cycle to then continue to be high until the sixth cycle, is even in countries like Belgium, my country, where IVF is to a great extent reimbursed. The fact that people discontinue treatment has an effect on our cumulative success rates. If people would not discontinue treatment, success rates would be better. IVF discontinuation or dropout is the decision of a couple to opt out from IVF for more than 1 year while they are advised by their gynae to continue treatment, while treatment is reimbursed, so they're still able to afford it, and while they still want to have a child. Current dropout rates in Belgium or in other countries where treatment reimbursed are within the first 3 cycles about 14%, and within the first 6 cycles about 29%. And research has shown that if dropout rates would be prevented, then our cumulative success rates would be higher. We would be able to get pregnant patients for more than half of the patients in case of 3 cycles, if everyone would go on with the 3 cycles until pregnancy. And we would have very high success rates if everyone would go on with 6 cycles. So dropout is important. It's important to prevent dropout, and especially in the patient population that's at discussion here, in patients with repeated implantation failure, because for this group of patients, it's even more important that they start several treatment cycles and that they continue the treatment trajectory. So how can we prevent IVF discontinuation in the general population or in the population of patients with repeated implantation failure? Well, I first looked at the reproductive medicine literature, and there are surprisingly little studies on how to prevent IVF discontinuation with psychosocial or educational interventions. I have identified 4 RCTs evaluating a psychosocial or an educational intervention. In the first RCT, natural IVF was compared to a controlled ovarian stimulation IVF. So they looked at the different strategies in treatment and their effect on IVF discontinuation. And they didn't find a significant difference in IVF discontinuation between the natural IVF group and the controlled ovarian stimulation group. And there was a study of the combined groups of Professor Domar and Professor Boivin studying whether self-administered interventions, actually a combination of two self-administered interventions, relaxation exercises in combination with a positive reappraisal coping intervention, resulted in less treatment discontinuation than standard care. And this was quite interesting because they did observe a trend that the control group discontinued more often than the intervention group administering these two self-administered interventions. Then there was a very interesting group of the group of Pook et al. In 2005 who studied the effect of a very simple information leaflet. They studied whether patients sent an information leaflet in preparation of the fertility workup, so male patients, whether they discontinued less than male patients who were not sent this information leaflet in preparation of their first fertility workup. And they showed a significant difference in discontinuation. So actually they showed that more men showed up for the treatment which they made, the treatment appointment which they made, if they had received the additional treatment information. And then in a fourth study, the group of Professor Boivin looked at an information leaflet on the link between female age and fertility results for partnered women. And they found that if women were sent an information leaflet informing them about the effect of age on fertility, then they were more likely to try to become pregnant and to actually conceive than women who were not sent this information intervention. So what I learned from this, if I look at this overview of studies, I actually see that information could be an interesting and quite simple strategy for decreasing treatment discontinuation. And treatment information is especially interesting to me as a midwife, because that's exactly one of the many, but it is exactly one of the things that we are good at. We're exceptionally good at that. And that's often our function in fertility clinics, is to inform patients. Well, it would be interesting to find out whether if we would do this in a more systematic, in an even more thorough way than we already do, whether we could decrease the IVF discontinuation rate. So it would be very interesting for increasing our clinic success rates and helping our patients, especially those with repeated implantation failure, conceive. So starting from this literature, I decided that this was something I wanted to research further. So midwife-led interventions focusing on information and their effects on IVF discontinuation. So I first had to look at a model for limiting treatment discontinuation. And I decided that I wanted to use two different strategies for limiting treatment discontinuation. I wanted to see whether I could limit treatment discontinuation by decreasing patient distress with patient information. And if the stress would be decreased, I hoped that then IVF discontinuation would also be decreased. Another strategy that I wanted to explore was if I provided more information, whether that could increase patients' knowledge, and whether this, in turn, the increase in knowledge could decrease IVF discontinuation. And I actually also looked at a lot of interesting qualitative studies, also often coming from fertility nurses and midwives from around the world, like Val Paddy, like fertility midwives from Iran, like myself. We've done a lot of very interesting qualitative studies on real-life experiences of couples. And these had shown that patients are overwhelmed by all-encompassing information settings at the beginning of treatment. And they want paced procedural information that comes right before the procedure. And there are also some studies from nursing researchers from Turkey showing that a lack of procedural information causes distress. And other surveys have shown that distress is one of the main reasons named by couples for IVF discontinuation. So this seems like an interesting avenue. On the other hand, we know that patients have unrealistically high expectations of their own treatment cycle. One of the studies of my group showed that patients expect a 60% success rate from their own cycle. But another study of my group also showed that patients are very interested in receiving personalized prognosis rather than average clinic prognosis. And interestingly enough, Val showed in one of her qualitative studies that high expectations when doing an IVF cycle led to distress when they then later on in the cycle were confronted with negative pregnancy test results, and that this ultimately could contribute to IVF discontinuation. So this also seemed an interesting avenue for me to explore further. And also interesting qualitative study from Helga Sol Olavsdottir showed that partners share discontinuation decisions, so that if we want to affect discontinuation, it's interesting to administer psychosocial or educational interventions to couples, to both partners, and to look at the effects of that in both partners. So if we go again to the model of prevention of IVF discontinuation that I worked on, I first designed one study, the POEM RCT, that provided general information which I hoped would decrease patient distress and which would then in turn decrease IVF discontinuation. In a second study, the GAP RCT, I wanted to look at personalized information, providing personalized prognosis, because I expected that providing personalized prognosis could increase patient knowledge on realistic expectations and could therefore decrease IVF discontinuation, because the expectations would simply be more realistic. So let's now look at our research on the prevention of IVF discontinuation and the progress that we've made, because I will already tell you, I can't tell you the results on IVF discontinuation yet, because as you know, IVF discontinuation, it takes a while. You have to follow up all the patients in your RCT for 2 years. But let me show you how far we've gotten. So let's start with the POEM RCT. In the POEM RCT, we provided patients of the intervention group with additional procedural information. It was a detailed film on the patient journey on the day of oocyte aspiration. The film starts with showing the patients the entrance of the clinic. It then shows where the man has to provide his sperm sample, in what kind of room, who he will have to give that sample to afterwards, which questions will be asked. It shows the woman how she has to register in the hospital, when she will be appointed to her room, what her room will look like. And then it shows her the whole journey from her hospitalization room to the surgery ward, where her oocyte pickup will be performed, and then back to her room until she's sent back home. So the whole patient journey summarized in a 5-minute smartphone-proof video clip. Our hypothesis, I studied this together with my PhD student, Louise Diaz. She's also the head midwife of quite large clinic in our country, in Belgium. And our hypothesis was that procedural information on oocyte aspiration would decrease anxiety. So we expected that the couples who would be sent the little video clip would be less anxious on the day of oocyte aspiration. We wanted to study this in an RCT because RCTs generate the highest level of evidence. We used a one-on-one allocation sequence. We were not, no one except for the statistician was blinded. And we included couples starting their first IVF cycle, because these are the couples that don't know what an oocyte aspiration day will look like. Our primary outcome was anxiety in women, assessed with the state anxiety questionnaire. And our secondary outcome was anxiety in men. And we also looked as a follow-up outcome, we are currently looking at IVF discontinuation. Our a priori power calculation indicated that we would need to randomize 95 couples per group, taking account of the couples that would might also stop during the study procedure. And for our analysis, we planned to conduct intention to treat analysis and independent sample t-tests and chi-square tests. So this is the flow of our study. Louisa recruited her patients at the IVF intake, so the big information consult 1 to 3 months prior to the first cycle. On the first day, and then she already randomized the patients. On the first day prior to oocyte aspiration, when she called the couple, she asked the couples of the intervention group to look, both of them, at the video clip, which was sent to their smartphone, and the couples of control group just received care as usual. Upon arrival at the clinic for oocyte aspiration, both couples filled out questionnaires, and then after a couple of years, we follow up all the files to assess IVF discontinuation. So what did we find? Well, in the end, we had data on 76 couples in the intervention group and 79 couples in the control group. And we saw, regarding our primary hypothesis, that the video clip did not affect women's anxiety. We did see, however, that the video clip decreased men's anxiety, and that all women and all but one man recommended the video clip to others. So it seems that we have most effect in men. It could potentially be because men have less a priori information and women are already quite well informed. And we're currently conducting a process evaluation with a qualitative study to examine if that hypothesis is correct. So just summarizing with respect to the model, information provision did decrease men's distress, but it did not have an effect on females' distress. And we're still following up to have a look at IVF discontinuation. So whether the effect in men results on a positive effect on IVF discontinuation. So let's now look at the second evaluated strategy that was evaluated in the GAP RCT. So what was our intervention in the GAP RCT? We decided that we wanted to provide couples with their personalized prognosis. We provided them on the day of embryo transfer with a leaflet stipulating what their personalized chance on a live birth from this oocyte aspiration would be, so including all embryo transfers, both the fresh and the frozen, from that same oocyte aspiration. We had a very thorough method for calculating the personalized prognosis. We had before published a paper where we validated the model of van Loenersloot on our data. And as you see here on the little graph below, we showed that the prognosis that we provided was very much in line with the later on observed chance of pregnancy. And we calculated the prognosis based on 5 clinical variables like age and 5 IVF laboratory variables like embryo quality. So what were our methods? Well, I did this together with my PhD student and embryologist, also leading embryologist at the Leuven University Clinic, Hanne de Vroo. And our hypothesis was that gynecologists' advice on personalized prognosis on IVF live birth results in more realistic expected live birth rates. So we wanted to affect the proportion of women and men that had realistic expectations, and unrealistic expectations were specified as expecting a success rate of 100%. And yes, as you of course know, as nurses and midwives, people do expect success rates of 100% exceptionally. But another form of unrealistic expectations was when people expected a success rate twice as high of their personalized prognosis. And our hypothesis was that unrealistic patients who received the intervention would then become more realistic. We conducted an RCT to generate, again, the highest level of evidence. And our study population were couples going through their 2nd to 6th IVF cycle. Our primary outcomes were the proportion of women with unrealistic expectations, and secondary, we looked at the proportion of men with unrealistic expectations. And again, as I said, unrealistic expectations is expecting 100% success rate, or a success rate twice as high as your personal prognosis. Then you are not so realistic. Our power calculated dictated a sample size of 80 women per group. And this would allow us to show that instead of half of the couples being unrealistic or half of the women being unrealistic, only 1 in 4 women would be unrealistic. We've conducted an intention to treat analysis and compared groups with key square tests and also independent sample t-tests for secondary outcomes. So let's look at our methods or our flow chart in more details. So on the day of oocyte aspiration, Hannah randomized the patients with a computerized program. And on the day of embryo transfer, the couples of the intervention group received the personalized leaflet with their personalized prognosis. And the couples of the control group received a leaflet with only a photo of their embryo. And the intervention group also received a photo of their embryo. So it was actually an attention control group. And then we looked at expected IVF live birth rates on the day of embryo transfer. And we followed the couples up to look at their IVF discontinuation rates. And as you see here, we finally ended up with 69 women in the intervention group and 66 responding women in the attention control group. And we found that sharing a prognosis did affect women's unrealistic expectations. Women were less likely to be to have unrealistic expectations in the intervention group. In the intervention group was 1 in 3, than in the control group, where it was 1 in 2. We found as a secondary outcome that sharing prognosis did not affect men's unrealistic expectation rate. We did, however, observe a trend in the same direction as for women, so in favor of the intervention. And when we asked people who received the intervention whether they would advise the interventions to others, they would. So if we look at our model for prevention of IVF discontinuation, we've shown that IVF information provision increased the knowledge of women and that there was a trend in men. And we are still following up our patient cohort to look whether this could have an effect on IVF discontinuation. So to end up with the implications, to the best of my knowledge, there is no psychosocial intervention or an educational intervention for which we have RCT level proof that it limits IVF discontinuation. So there is no such intervention which I could now advise to you to widely implement into your clinics to increase the persistence of patients with repeated implantation failure. But we are working on it, and my group is working on it, and I'm sure that other people are also looking at the effect on IVF discontinuation at the moment, because this is what we all want to do to increase patients and our clinic's success rates. And my group is awaiting the follow-up studies of our 2 RCTs. And if I look at the 2 studies, I think that sharing the prognosis seems most promising because we have an effect in women, on women's knowledge and on men's knowledge, and because we have qualitative studies suggesting that it's exactly unrealistic expectations that are pointed at by patients who have continued treatment. So thank you for your attention, and I'm looking forward to the discussion on Friday afternoon.